First of all, I wanted to give you just a little bit of history. There's been a lot happening in maternity over the last 10 years, I would say. Probably from the work of the Perinatal Mortality and Morbidity Review Committee that's just published its 10th annual report. And they showed that there was some work to be done, really. And from that, there's been quite a lot of discussion on how we could improve our maternity services, and a number of organisations have been formed, or groups been formed, to look at how we could do things better. And I've mentioned the two on the slide below because they've got direct relevance to us in general practice, really. So the National Maternity Monitoring Group is a group that monitors sort of things on a more overall scale. And their first recommendation that they've put out for the last 2 years has been consistency in the quality of the first trimester care, saying that we've got to nail this. We've got to, as health professionals, if we're working in this area, we need to be well informed, and we should make sure that we cover what's evidence-based and do a really good early pregnancy consultation. Maternity clinical indicators, there's about 27 of them that they look at how all the DHBs are doing on this, and their first indicator is registration with a self-employed midwife in the first trimester of pregnancy. So it means that we not only need to do that good first visit, but we need to get our woman booked in with a midwife early. So the early engagement group was an Auckland regional group, and they went around a lot of GP practices in our area to see what GPs were doing. And they actually found it was very variable. We know that there's a lot of pressure on your time, there's a lot to do in one consultation, and that some people were doing a really good job and some people weren't. And some people were just saying, hey, here's a list of midwives, go and find one. And that really is not what we should be doing. They wrote to the Ministry of Health and said, what do we do about this? And the feedback was very clear. Best practice, which is what we all want to be doing, is a full first antenatal visit following the requirements set out in Section 88 and including the referral to the midwife. So what is Section 88? Well, it's a legal document. It's an Act of Parliament. It's very difficult to change or do anything with, but it stipulates very clearly what services there are and what payments there are for that. And the list of what's required for a non-LMC, so that's for a GP first antenatal visit, is what I've given below, which is quite long. Confirmation of the pregnancy, review of past and current health status, options for choosing a midwife, information and education and referral for screening, written health information including results to the woman and her midwife, information and education on nutrition, smoking, alcohol, drugs, literature provided to the woman, appropriate assessment, so this is your examination, your blood pressure, uterine size, etc., and management of a miscarriage and a TOP. And for all this work, you will get a one-off payment of $113 for the first trimester care. That's a package payment. It's regardless of how many times you see that woman. If it happens to be a threatened miscarriage or a termination of pregnancy, that goes up to $154. The good news is that both the midwife and the GP can get this sum of money. So that's to encourage us to do that good first visit, to refer them to the midwife, and the midwife can also get them started on their road early in their pregnancy, looking after all their health needs. So providing good quality care. The first thing to know is that most women actually do come to their GP, so 80% are turning up for their pregnancy test or their first visit. Booking with our midwife, I can't say that enough times, really, early in their pregnancy is really important. And that we should all be seeing midwives as part of our primary care team. And I did a little bit of a Google search looking at what was happening around practices, what do we advertise? So there's 24-hour doctors, there's specialists, physios, pharmacies, there's even dentists and optometrists, and only one could I find there was midwives. So I know we're really busy. I know there's time constraints. I sort of had to think about what we could do to make that a bit easier for ourselves. Maybe if the woman says that she's coming because she's just pregnant, we could book a double appointment. Maybe we could book a GP and a nurse appointment at the same time, or make better use of our practice nurses. Or maybe get them back for 2 appointments and share that funding over 2 slots. So the first antenatal visit, the first thing I think that we need to do is just allow the woman a bit of space. Discuss this life-changing event with her. Congratulate her. We've certainly had feedback from women that they come in, they get a positive pregnancy test and the doctor's just business as usual. For this woman, it's not business as usual. Is she happy? Was it planned? How will it affect her life? What happened last time? There may be all sorts of issues she had from her last delivery, and we certainly know that post-traumatic stress disorder with over deliveries is not uncommon. And quite a number of my women come in and say, okay, this one's all right, but no more, please. And it's never too early to start the contraception question and the larks, and it should be a question that carries on all through the pregnancy, because I think, as Helen was saying to us, we're really missing out with our postnatal mums. So, in terms of what you need to do in that visit, I think we need to go to our antenatal first consult, go to the Auckland Regional Health Pathways, and they put it so much better than I could. If we scroll down a little bit, it tells you exactly what you need to do, really. There's so much information on there. So I just pulled out a few things. If you read it, it sort of starts off with the symptoms, it goes to the history, medical, mental health, obstetric, social, goes to smoking, alcohol, drugs, medications, just so you don't forget things. Examinations, blood pressure, cardiovascular system, BMIs. There's some information on STI screening, high vaginal swabs only if they're having a termination of pregnancy, remember. Chlamydia screening, opportunistic for certain categories, under 25s, over 25s with new sexual partners, etc. That's at the top of the practice point, chlamydia screening. And if we go down, urine test, dipstick for proteinuria. If it's asymptomatic bacteriuria in pregnancy, we need to treat on a single sample and treat if you've got a single bacterial strain of greater than 50 times 10 to the 6, then we need to treat on urine culture and do, according to the urine sensitivities. Do a test of cure 1 week later and monthly through the pregnancies. Urinary tract infections can be really important in pregnancy. And management, it talks about, again, booking with the midwife, top thing to do. Starting medication, your iodine and your folic acid, and following up any medical conditions. I haven't talked about scans and bloods because we've got that later coming up in our discussions. So all sorts of useful things on the pathway. If Christine's going to go to me. What dose of folic acid do you use for women with a high BMI? There. Or other reasons why you need a higher dose. What's the first line hypertensive agent for a woman with pre-existing hypertension? Medical conditions. Hypertension. Scroll down. You're pre-existing? There we go. And it's all there. When do you check for a thyroid function test? So you need to go back to our pathway because we've skipped to a new one.
Learn your back. How to go
Lean
back.
Okay. So just trying to demonstrate just how useful that pathway is. The miscarriage one, I'll just put a plug in for that too because it's excellent if you can't remember the sizes of the sacs that you need for when you can see a fetal heart. It's all on there. Okay, and I'm just going to talk very briefly about our first contact pregnancy pack, which Counties Manukau is putting out for all our women. Auckland DHB might have to catch up. So what we found, we did a pilot and we found that women want them. our consumers were involved in producing them. It fulfills the Section 88 requirements, so it's giving the literature that you have to give, it's giving the information that's there. It gives consistency in the consultation, so you know that you've covered what you need to cover. They're free to practices and counties, funded by the DHB. We just encourage you to ask the woman to take it to all their appointments. And as an extra bonus, if you could put your referral letters that you write to your midwives, yes, maybe. I mean, what other group of health professionals do we refer to that we don't do referral letters? So pop your letter inside there with the results that you've got, and she can take that to the midwife. So very quickly, when we sent these packs out to all our practice nurses, we sent out a supporting notes to go with them so that the practice nurses could have very quick discussions with the women over the different pamphlets. So that's the cover. There's a checklist on the back. Inside there's a space to write your name and for the midwife to write her name, because often we don't even know who the midwife our woman is seeing is. There's this one that's been around for years, the Ministry of Health one that has a little bit about everything. There's a new pamphlet, Options for Maternity Care, that we have produced that's got maps showing our primary birthing units to encourage our normal women to go to primary birthing units. A list of self-employed midwives that are colour-coded by the region that they work in to make it easy for women to ring the appropriate one. There's the folic acid and iodine sheets. There's healthy eating and food safety. Pull out the guide and the food safety over what you need to eat. It's got a lot of foods listed to, that's an easy guide, easy reference for the woman. Healthy weight gain in pregnancy. I think we're just beginning to discover some of the, well, I think we know really some of the effects of excessive weight gain in pregnancy really, and asking our practice nurses to fill these out and give the women some idea of how much weight they should put on during that pregnancy. Smoke-free, Counties has got the smoke-free services that has the best results of any smoking cessation. $300 available for women that stop smoking through their pregnancy. Drinking, not any time. We just don't know when safe and just not. My favourite pamphlet is the unhappy card, this little pink one, and it just has some little questions for women. Are you tired, worried all the time, not coping? Not thinking clearly, feeling sad, feeling empty. So just some prompts to them to maybe it's something they should talk to their doctor about or seek help with. Safety plan, need to have those conversations. HIV testing, we're going to talk about more. Breastfeeding, we're going to talk about some more. Beautiful pamphlet, lovely pictures. Down syndrome and other conditions. The message from that is go and see your midwife by 10 weeks so you can get your scan at 12 and a half if you want a nuchal scan. Cervical screening, I had to fight to get this one in there. I've seen too many cervical cancers and in young women with kids. When they're pregnant is just too good an opportunity. It's the chance that you might get to do a smear that the woman won't let you any other time. Grab it. Christine's going to talk about immunisations. Put a recall on for 32 weeks so you can come back and get your Boostrix immunisation, and if it's appropriate, give the flu vax when they're there. And lastly, but not least, contraception, all the way through. People's choice. It's all about choice.